Good afternoon and welcome to this week's The Double 15 Minutes with me, Rupa. So, how is everybody feeling this week? Our 6th week in lockdown number 3, or is it 5 weeks? I don't know. I'm actually losing track of time. Most days I don't even know what day of the week it is, but I think it's because that's the new normal. I think working from home, you do tend to sort of like each day melds into the next, but there you go. So we've had Mangesh joining us. Thank you for joining me. We've got people joining us from LinkedIn and YouTube as well. So welcome to you all. Today we are talking all things Alzheimer's and dementia. Now, mental health has been in the news quite considerably since the start of the lockdown. And prior to that, it was beginning to, gain traction in terms of us understanding that without our mental health, we have issues with our physical health. So that was one thing that was beginning to come into light, especially with the new NHS 10-year plan. However, one group of patients that have maybe not been as well in the public eye as they should have been, and that is our elderly patients or those patients that have dementia and Alzheimer's, especially with those that are living in isolation, that are maybe living on their own, or that are maybe at the early stages of dementia, so maybe they haven't even been picked up as having dementia or Alzheimer's. So today I've got an absolutely fabulous old age psychiatrist joining us. So not that he's old age, he's a young psychiatrist, but he works within the elderly population, Dr. Mangesh Marudkar. Now, he's got over 25 years experience as a psychiatrist, an old age psychiatrist in the NHS. Mangesh was also Associate Medical Director of Education for the Leicester Mental Health Trust, as well as an executive of the Faculty of Old Age Psychiatry for the Royal College of Psychiatrists. And he also has a PhD from Leicester University, specialising in Alzheimer's and dementia. Now, Mangesh is a font of a lot of knowledge on this, and I've had the absolute pleasure and privilege of working with him in a previous life, and I can tell you now he is an absolutely brilliant psychiatrist, really cares about his patients and is so passionate about getting the information out there about Alzheimer's and dementia and how patients can live well with it, because we do tend to focus on the negatives of Alzheimer's dementia, and we will cover that. But Mangesh is very, very passionate about how we can help patients live well with dementia. And when we talk about patients, we don't just mean the patient that has Alzheimer's or dementia, we mean their wider family and friends network as well, who are very often forgotten in the treatment of the patient. So we've had quite a few people joining us. Let me bring Mangesh on first, and then I will go through the people that have joined us. So, Mangesh, thank you so much for joining.
Good afternoon to you, Rupa. Thank you very much for having me on this show. It's my honor to be with you and be with my audience. So greetings to them as well. And I look forward to sharing some of the thoughts that I have kind of acquired over the last several years with all of you.
And we are very much looking forward to that, because like I said, Mangesh, it's like, I think, you are so passionate about education and actually creating a wider awareness that actually it is very inspiring to see that, because, you do work tirelessly to ensure that people are made aware of this, made aware of the plight and, sort of like trying to find positive ways around it.
Absolutely. And as you said, these are the silent patient. You don't hear too much about them in the media. They're not the people who would spontaneously seek out and make loud noises about their needs. Often they keep quiet till it reaches a pretty bad state, which is a shame, really, because a lot of the benefits can be accrued through some early intervention and knowing what is the matter early enough, or even before that, preventing some of these things from happening in the first case.
Yeah, no, absolutely, because that is
we need to intervene, and we need people to be aware of it so they can do something about it.
Yeah, and we will go through that step by step, because that's what we've said that we were going to do. And what you said is the prevention side of it, which is part of the NHS 10-year plan. So those of you who are not in the UK that are watching this, we in the UK are very, very lucky and very blessed to have an amazing health system called the NHS. We are very, very blessed with it, and they, every few years will create a new plan. But this last plan that they've done, the 10-year plan, they are talking about prevention being better than cure. So before we go on, I'm going to go through the people that are watching with us, Mangesh. So we've got, like I said, Manjira Kara has joined us, Usha Happy, Sangeeta Stoman and Drupti Nayak, Sonali Nayak, Manjusha Godbole, Manas Marudkar, Asmita Bogait has joined us, Nazir Alam, Rama Joshi has joined us, Vaibhav Dattar and Sakshi Joshi. And we have got quite a few people that have joined us on LinkedIn, YouTube that I'm unfortunately not able to see the names for. But Mangesh, before we go dive right into the Alzheimer's and dementias, can you just tell us a little bit more about your background, where you come from, and what made you go into psychiatry?
Ooh, long story. I'll keep it short. Yes, I graduated last millennium, you could say, in India, and I did my post-graduation from Chandigarh, having graduated from a city called Indore. I came to UK in 1994. I went through some of the training here, and I've been a consultant for the last 20 years or so.
Yeah.
I've been an old age psychiatrist, but as a part of my basic training, we get training into different ranges and different specialties within psychiatry. Once I became a consultant, and I wanted to get to know more, learn more about science of old age psychiatry, in particular dementia. So I undertook a PhD from Leicester University, which I finished in 2008. And I must say, every day I learn so much talking to patients, listening to patients, and just listening to people, a common man, because I might know one or two things about science of Alzheimer's or dementia, but it's not a material science. It's a humanistic science. So it's important that we apply that science to individuals, and each individual being a unique person, we need to translate that knowledge into what is more relevant and applicable for that person. And that's why there is no single formula that fits everybody. We have to work what's best for that person in that situation at that time, and that those are the key elements of it. Just reading a book and knowing a thing or two about Alzheimer's or dementia is not enough to give the best for the patient.
Yeah, and I'm glad you've said that, because the one thing, and this is sort of like in a previous life when I was working within mental health with yourself and the other sort of like Leicester psychiatrists who maybe I'm biased, but I just think you guys are sort of probably the best in the country as far as I'm concerned, because and I'm glad you've said that, because you guys all deal with psychiatry in a humanistic way, rather than a this is the DSM-4 and this is this sort of like document that we have to use and we're going to tick boxes. You don't. You actually treat every single patient as an individual, and I think that's what most psychiatrists do, and I think that's why it's like you said, it's a humanistic science.
Absolutely. I think that's a challenge. You asked why psychiatry, and it's one of the branches where that human interaction, that clinical judgment, that listening, keeping your eyes and ears open and trying to establish is at its best, because although the science is making advances and we have more and more investigation, but till date, there is no single lab test or a scan or anything which can diagnose dementia. It has to be a clinical decision based on a whole set of information. That is challenging, but it's also rewarding. It's not an algorithm where you say A, B, and C makes it D. No, it doesn't.
Yeah.
You kind of contextualize everything and then come to a judgment.
Yeah, no, absolutely. And I think, you again hit the nail very much on the head in terms of the reward side of it, because if you do find, with a patient, if you find a way or managing their illness in such a way that actually you can help increase their quality of life and increase the quality of life of their carers, because that's another group of patients that are very much ignored, because they may not necessarily be your traditional patients, but they are. But before we go further into that, let's sort of like go right back to basics, because Alzheimer's and dementia, they're both terms that are used interchangeably. Are they both the same thing?
They are not the same. I think people use Alzheimer's and dementia interchangeably. You're quite right. And one of the reasons is Alzheimer's is one of the most common forms of dementia. So dementia is a more general word. In kind of plain English, if I have to say it, it applies to a collection of signs and symptoms you see in people where there has been some evidence of damage to the brain over a period of time. Mostly that damage is building up and is getting worse over a period of time, and the damage is of such a degree that it is affecting that person's ability to undertake their day-to-day functioning to the same level that they were doing before. And so that's dementia. Now, there can be a number of reasons why there is damage to brain, and depending on either the nature of the damage to the brain or the location where the damage is starting, you can have different illnesses, and Alzheimer's is one of them. There are different types of dementia. There are more than 200 types of dementia if you read the books, but most of them are very rare. The 2 or 3 common dementia you see, which covers about 80 to 90% of all dementia. As you say, Alzheimer's is about half of the population of dementia sufferers have Alzheimer's. So about 50% people with dementia will have Alzheimer's dementia. Another 20, 25, 30% people are likely to have dementia due to what we call a poor circulation to the brain, or vascular dementia. People will hear other words related to that. Multi-infarct dementias, and there are all sorts of technical words, but essentially what it means is that the damage to the brain is because of insufficient blood circulation. While in Alzheimer's dementia, the main reason is that the cells are dying from within. The mechanism within the cell itself is breaking down, and the cells are dying. This is called neurodegeneration. So, leaving the technicalities, those are the 2 most common types of dementia, either due to degeneration of the cells, which is the Alzheimer's mainly speaking, or the poor circulation in the brain, leading to people who had multiple strokes, or who had what they often call as TIA, which is kind of mini strokes. Over the period, that accumulation of the damage leads to the person's brain not being able to undertake what is needed to get on with day-to-day life. And that is where we call it a vascular dementia. And of course, then there are other less common dementias. So you have dementias in people with Parkinson's disease, dementias where it affects their certain parts of the brain. So it's called frontotemporal dementia. And then the list goes on, basically.
And it's quite interesting. So you were saying about sort of like a series of mini strokes. So basically, sorry, before I go on, we've had a few more people joining us. So we've got Vaibhav Dattar. We've had some comments coming in. So Nasir Alam, he's saying, this is Amir, Director, Aleph Company, AI Learning to Enable Predictive Healthcare. We've had Dr. Meena Chabra, who's saying she's a diabetes specialist from India. Nanda Kochela saying thank you. Meena Chabra saying, and this is a question we'll come to as well, are vegetarians more prone to dementia due to vitamin B12 deficiency? And if we could hold on that question for a minute. Raj Patel has joined us saying, excellent show, Rupa, and great to see you, Mangesh. And Yasir has joined us from Pakistan. He's saying, my father was diagnosed with Parkinson's about 7 years ago. 2.5 years ago, he contracted double pneumonia and things were worse because of lack of oxygen to the brain. He does exhibit signs of dementia and there are Lewy bodies visible. So the question being is, this was the thing that I was actually going to get to. You know, you mentioned the series of mini strokes. When a patient does have these mini strokes, is there anything sort of like externally visible to outside, or is it just the patient themselves that will start feeling, I suppose, not particularly well?
Well, I mean, talking about the mini strokes or the what you know transient ischemic attacks, or which is a kind of more technical name for them, you do see, often the person themselves may not be aware of it because the way nature of the brain functioning is such that when there's a sudden insult to the brain, often the memories for that event are not there. You would see that in people who are having road traffic accidents or bang their head and lose consciousness, that they themselves are not necessarily aware of what happened. So in a mini stroke, essentially anybody observing them will suddenly see, and this is very popular, we say, the face, the alertness level, whether they can lift their arms, or weakness of one part of the body or another, face drooping, the speech getting affected. You can see all these signs are coming all of a sudden, which is a sign of a stroke. The main difference between a mini stroke and a stroke, for the want of a better word, is a mini stroke resolves pretty quickly within 24 hours. And often it doesn't leave any permanent visible damage on the brain scan, which is not to say that there's no damage, except the damage is too subtle to be picked up by the scans at that time. And thankfully, it clears off. And the common causes are blockade of the blood supply. And if that blockade gets kind of shattered, because as soon as there's a blockade, the body's mechanism kick in to try and unblock it. Sometimes body mechanisms succeed, and before a permanent damage happens, the blood supply may resume, and so the functioning may regain. And so that's what is a transient ischemic attack or mini stroke.
Okay.
If it lasts for long enough to cause the permanent damage, that after that, even if the blockage gets unblocked, the damage is already done. So what you're left with is a stroke, where recovery and rehabilitation can be slow and it takes longer.
Okay. So going to Mina's question, and I'll continue with my questions in a minute. Going to Mina's question, where she said, are vegetarians more prone to dementia due to vitamin B12 deficiency? What is your knowledge and experience of that?
Mine, if there is a vitamin B12 deficiency, that is known to cause memory problem. We know it is one of the known factors for causing memory problem. Thankfully, it is one of the factors which is reversible. So if it gets picked up, and if there is vitamin B12 deficiency, then it can be easily replaced, relatively speaking, and any memory deficit or that you can get can be reversed. The trouble is often and again, I'm going to come to that later on. Sometimes it takes years before anybody checks it, and people often avoid going to doctors and avoid having regular checks. Clearly, B12 deficiency can be for a number of reasons. Some of it is because of the dietary factor. Some of them are due to intrinsic factor, where although you might be having a lot of B12, it is not getting absorbed in the body. So there could be other reasons. And I think it's a pretty pertinent time to also mention that not all the memory problems are because of dementia.
Okay.
And there's a tendency that people blame any memory problem to somebody who might already have a diagnosis of dementia or may not have a diagnosis of dementia. They worry this is dementia. And because the perception is, well, nothing can be done about it, there's no cure for dementia, people often take a view, why bother? And hopefully we'll get to talk about a lot can be done about dementia. Of course, most of the dementias are not curable. We know that. And sadly, the science is still working to try and find a cure or remedy where it can be undone. For the time being, that is the situation, that most of the dementias are not curable. But it doesn't mean we can't do anything about it. A lot can be done. And in that sense, the dementia is like any other chronic disease. You talk of arthritis, you talk of chronic lung diseases, you talk of any chronic condition, hardly any of them can be cured. In my other talks, I often say to people, tell me what can be cured other than infections. If you talk about it, heart diseases, lung diseases, kidney diseases, and in that sense, the brain diseases are no different. Dementia is a chronic disease, and it needs to be managed like a chronic disease, where you can relieve the symptoms of the condition to a large degree. You can minimize the impairment because of that. You can reduce the risk. You can help build the autonomy or maintain the autonomy in a way which maintains their quality of life.
Because That's what it is. Now, here's the thing I wanted to ask you is because, we're saying, and it's something that you just said now in terms of people sort of like putting the label of dementia on certain behaviours. How can you tell the difference between somebody who actually genuinely has dementia and somebody who just because at a certain age, we all, even youngsters, I've done this, and I think we've all done it, where we've decided, right, okay, I'm just going to go and do something. And you walk into the room and you're like, what was I going to do? I've completely forgotten. So when does that sort of like the usual forgetfulness then start rolling over into dementia or Alzheimer's?
Indeed, and I think that's one of the people come to us being worried about developing dementia, and I think it's fair to say that the line between dementia and the normal age-related change can be a little gray at many places. So it's not a watertight compartment where you are either on this side or that side, and people often can be in a kind of in-between zone for a long time. The 2 or 3 kind of, I think the only way to be as certain as one can be is to get a assessment done, I suppose. And it's hard to kind of give some general sweeping kind of statement which will distinguish the two. But really, if you have to kind of look at the major kind of significant differences between the two, one of them is change with time. Dementia gets worse over a period of time, a lot more quickly than what happens in an age-related memory change, which can happen very, very minimally over many, many years. And second thing, dementia doesn't come overnight. It's a chronic condition. And according to, you mentioned about DSM-4 or the other kind of international diagnostic criteria, it needs to be there most of the time or all the time for at least 6 months or longer for one to seriously think this is likely to be dementia. So if you're just confused for a few days, well, the good chance is it's not dementia.
Yeah. Okay.
So yeah, and I was saying the other thing is often how it is impacting your day-to-day life. In a normal forgetfulness, people are able to work around that confusion, that forgetfulness, and mostly get on with their day-to-day life reasonably well. But if you see somebody whose ability to undertake their day-to-day living, their domestic skills, their skills at managing their affairs, be it finances, be it shopping, be it social aspects of things, if you see there's a kind of progressive decline in that over a long period of time, that's where one should be concerned that this might be dementia. It could be other thing because a lot of other physical ailments and vitamin B12 deficiency is one of the name mentioned there, but a lot of hormonal imbalance in the body, some chronic infection, some chronic kidney problem, some breathing problem, lung disease if you're not getting enough oxygen. All of them can mimic as dementia.
Okay.
And just by looking at it, it may not be possible to separate out. That's why for anybody who comes for an assessment of dementia, the first thing the GP does or we do is to make sure we get all the relevant blood tests done to check that there is no deficiency of any hormones, the vitamins, the basic nutrition. They are not anemic. They don't have any signs of infection. Once you have cleared all those things, only then one could say, okay, let's confirm whether there is some other kind of damage to brain happening, which might be causing these memory symptoms. So not every memory problem is dementia. And also in people with dementia, if you see the memory getting worse, don't automatically presume that this is dementia. More often than not, it could be due to something else. And we know commonly what we see that people who often, and I'm going to talk about the more likely to happen in elderly, but it's not an uncommon situation where elderly might have pain and discomfort. They might be constipated. Might have some medication which is making them sleepy, drowsy, and more confused. They might have some water infection or some chest infection, or they might be simply dehydrated. Sometimes elderly don't like to go and drink enough water, and every doctor up and down the country, and the I suppose must do educate people the importance of hydration. If you're not well hydrated, you're bound bit tired, you're bound to feel a bit fatigued, you're bound to feel more confused. And that can happen a lot more acutely in people who already have dementia. So not every memory problem is due to dementia, and not every worsening in somebody with dementia is due to automatically dementia getting worse.
Yeah. So it is sort of like just trying to get that diagnosis. So okay, so we've had a few more people joining us. So Tel's joined us, Britham Meras has joined us. We've got a few more comments. So Yasir has said, as a caregiver, the challenges continue, which we're going to be covering shortly. And then Rena said, does poor long-term diabetic control increase the risk of dementia?
Yeah.
And then Mina Chabra said, why is anomia common? You forget people's names but remember everything else about them. And Yasir is saying, what are the telltale signs of dementia, especially when there are other underlying conditions? Parth is saying, very informative. Vaibal, thanks, Dr. Mangesh, for the
welcome.
Manjira Kare, excellent informative. Mangesh, Meena Chabra, awesome information. So should we tackle sort of like the questions one by one? So looking at the diabetic prognosis.
Indeed. I mean, diabetes is itself a risk factor for both vascular dementia and also for Alzheimer's dementia. So a good control of diabetes certainly will go a long way in preventing or reducing the risk of dementia developing. Okay. And the mechanisms are complex, and I'm not going to go into them today because it's a bit too technical in that sense of the word. But in terms of preventing dementia, one other thing which we say, and we have to be kind of sensitive to people's kind of lifestyle, but all the thing which is good for your heart is good for your brain.
Okay.
So we know that fortunately, there's been a lot of advertisement around the world about what is good for heart, which is a good control of bodily parameters like blood pressure, your cholesterol, your sugar levels, weight control, diet, exercise, good sleep and good pattern of sleep, and all of those things are also, the research has found, are applicable for Alzheimer's dementia and vascular dementia. So there are no new thing. It is, if you follow what is good for your heart, chances are you will be helping your brain as well. And it is something which needs to be done over many, many years. Longer you do it, greater are the benefits. So often people kind of wake up one day when something bad happens and then they change their lifestyle, or they try to change their lifestyle. We just had January, and a lot of people have the New Year's resolution they make, I will do this and I will do that. And that's all well and good. But I think it needs to be part of your lifestyle rather than a discrete, I'm going to do something to prevent or reduce the risk of dementia. It is how you change your lifestyle so it flows naturally and you can sustain it. Certainly, I mean, if the research on these aspects is limited, and I'm going to talk about and plead to everybody to join in the research, because there is a dearth of knowledge, but what limited we know is that if we can deal with the preventative measures effectively, we could reduce the burden of dementia by about a third.
Yeah, and we're going to be talking about that sort of like later on. So so it was like we'll go back to the questions in a minute. There's a few other things here that sort of like in terms of what we're looking at. So we've said about the diabetes, but then the telltale signs of dementia, which I think you've covered sort of like throughout. But is there anything else that people can look out for?
Indeed. I mean, I think the telltale signs of dementias sometimes, as I said before, can kind of get a bit confused with normal forgetfulness that we all might have. So mislaying your keys, mislaying your wallet, not remembering somebody's name you would normally expect to remember, asking the same thing second time or third time, or going to the shop and coming back with something different to what you went to buy. Now, all of this happens to all of us at various times, even normally. And again, in a bit of a light-hearted fashion, some of us, families will adopt, he was born that way, he was forgetful, he was all, and there are sorts of kind of humorous or misplaced humorous comments and jokes people make about these things. So the key is to see the change from the baseline. We all have what we are, and it is change from that baseline over time, which is the kind of telltale sign that, hold on, this is not him, this is not her. If somebody was already into inverted commas absent-minded professor, and that's a word many people have used, and if that's what they are, then that's not a sign of dementia for them. They might not remember people or names, but then that's normal for them. So everybody has a normal, their basic self, and it change from the baseline, which is critical. Know whether there's a sign, this might be a sign of evolving dementia. And sometimes the transition can be painfully slow. And again, if you go back to the research and what the research on this field say, as an average, people say the time gap between people noticing the first sign of dementia and them getting actual label or diagnosis of dementia is about 2.5 years. So months and months pass by, and none of us want to think the worst. Sometimes we think, oh, well, it's just one of those things, it will clear up. And that is not just about memory. We do it to everything. If people are a bit of a tummy upset, most of us don't rush to doctor and get a scan done on the very second day. We think, okay, I might have eaten something. People think of something that will pass away. People have a cough and cold. We don't start antibiotic on the first day. We can let it say, okay, it might settle down. Same with the memory problem. And I think in majority of people it does, but in a small number of people it doesn't. And that's where, if it is going on, is not settling down, few months have gone by, suddenly, then once you start thinking, hold on, is this just age related? Is it just because, my mother had this or my father had that? Sometimes operations, surgeries can push the brain's ability to cope, and people can decompensate, but a lot of them recover after a period of time. Don't recover, that's when you have to start wondering whether this could be dementia.
Exactly. And we've had a few more people, so I'm going to go through this in a minute, but let me just sort of ask you, do people also notice a change in the personality of their family member that may have dementia? So, and what sort of personality changes are we looking at?
Well, there are two kinds of personality changes. One could be, you can say, reactionary. So, sometimes the nature of dementia is such that the person themselves are not aware of their forgetfulness. And again, not putting it too crudely, they forget the fact that they're forgotten. And because of that reason, as far as they are concerned, they don't know, they don't believe that they've been asking the same question third time or fourth time, or something or another. And that can cause a bit of a commotion and an argument between them and their loved one. And that can make them look irritable or a bit cross or a bit unhappy. And that could be one as a reactionary change in their personality, that, somebody who never shouted at me suddenly started shouting at me. Why? Because I've been pointing out to them that this is, you're asking again, they won't believe it. So it led to argument. Also, there are certain changes in personality which can happen as a part of dementia itself. So some of the brain areas or parts of the brain job is to regulate our behavior, our response, and our emotions. And if parts of the brain start getting damaged, then the control over the behavior, control over the emotions, control over our social thinking can get compromised, and people can behave in a way which is out of character for them.
Because there have been incidences, haven't there, where basically a lot of patients have lost their inhibition, so might display, may have been a very modest person, all of a sudden, strips down to underwear and goes out. Now, what about if the patient has maybe had an outspoken personality, but now has actually that trait, that personality trait, is now even more exaggerated?
Yep, indeed. And that exaggeration of your personality trait is one of the description of dementia, that people often rely more and more on their innate responses to deal with the situation, because they can't somehow craft a appropriate response for a given situation. So again, I don't know, any examples are bad example, I suppose, because as I said, everybody is unique and it's not fair. But sometimes people, if they're impatient or they're in a long queue and they think the queue is not moving forward, it's natural for everybody to feel a bit annoyed, a bit frustrated, a little bit, is the person at the counter working effectively enough? But we don't shout out obscenities or say anything inappropriate. You might find that feeling that we can control without the dementia, if that control is gone, you might see people saying things inappropriately at a supermarket checkout counter or somewhere where others might think, well, I feel the way you're feeling, but I don't think it is appropriate to shout out all those accusations or all those kind of thoughts you have. And that loss of control, if it's happening again and again, is again a sign that it could be a change or some damage to brain leading to change of behavior, which is what constitutes personality.
Yeah, no, I completely get that. So I'm going to go to a few of these comments now. So we've had a few other people joining us. So Sean Butt has joined us. Pratik Mishra is watching. We've had another comment. So Isha has said, really interesting. Actually, let me read it on here. It'll be easier for me to read it on here. Or maybe not. So Isha said, really interesting discussion so far. Thank you, Mangesh and Rupa. You may discuss this later, but is there anything someone in their 50s can do to reduce the risk of dementia? And that's from Sunil Savani. Sunil, we are going to be covering that later on. And then is there a link between, so this is from Anupama, is there a link between long-term statin use and risk of dementia? And we've got Drupti saying, very enlightening, thank you. Shilpa, Gauli, Dani is watching, Diljit Kaur is watching. Meena Chabra has said, is depression a differential diagnosis of dementia or part of it? And Britham has joined us and she's saying, thank you, Doctor and Rupa. How likely is dementia to be inherited and passed down by generations? And we've got Ajish John watching us and Meena saying, thank you for asking such relevant questions. And Lanuchuba Sangir is watching with us. So should we go, let's tackle
the... Let's try and cover them one at a time.
Yeah, so should we start with the first one, in terms of preventative, someone in their 50s or...
Indeed, yeah. So, sorry, the question was about, somebody in their 50s, what can be done to prevent dementia?
Yes.
That's right. And again, it is, whether you're in your 30s or your 50s or your 70s, what you need to do are exactly the same thing. And I'm going to mention a few specific here. For example, we have heard time and again through NHS, through government, through local governments and health trusts that 150 minutes of moderate exercise every week spread over 5 days or more is good for your body and your health. That applies to your brain as well. So being active about half an hour every day, 5 days a week, and again, not that I want to belittle anything, but when people are talking about walk, it has to be a proper walk which is leading you to have a little bit of sweat. A gentle stroll is better than nothing, but the benefit, to accrue the maximum benefit, the exercise has to be of a certain intensity, of a moderate intensity. And so if you're spending that half an hour walking in the park, you may as well make the most of it by making it of a certain intensity. Build it up slowly, don't rush to make it high intensity straight away. But that physical activity, we know, and I'm quantifying it simply because it's important to get a sense of what is adequate and what is too little or too much. It's not a dichotomous thing, but if you're spending half an hour every day, you may as well get the most of it by making it that much little bit intense so that you're just beginning to sweat. That is the kind of simple way to describe, well, I'm talking about Britain, depending on the environmental temperature, you might be sweating anyway. Again, diet-wise, we know that a diet saturated with high saturated fats and excessive calories is known to be having negative impact on lots of health factors, and dementia is one of them. It affects your joints, your heart, your you name it. And dementia is again one of the factors we know. So healthy, balanced, moderate diet with limited calories so that you maintain a healthy weight is important. Looking after yourself, keeping yourself socially and mentally active. One of the common theme I hear from senior citizens is that, and again, it's a sad reality in many ways, that as they grow older, their friends start dying, their contemporaries start dying, and their social network get less and less and less. And they find it extremely hard to keep themselves socially active, mentally active, because that common friend with whom they grew up this many years are not there. And it's a very, very unique and sad challenge. That leads to social loneliness. You might be amongst 20 other people, but if you're not mentally connected to them, emotionally connected to them, if you don't have something common, shared experience or feeling, you can talk and laugh and cry, you might still feel mentally lonely.
Yeah.
And to push against it, some of it is unavoidable, because clearly with age people die, and your friends, and we know that happen. But to keep building your social network such that you have your, put it in a simple way, you don't put all your eggs in one basket. You need to have variety of interests, variety of activities, variety of engagement, where if you can't get one, you've got alternative options to keep your brain, keep your mind, and your mood. I mean, these have a positive effect on your mood as much as on your memory and your brain. So keep mentally and socially active is another important thing to do. One last thing I would mention is people often, as I said before, don't go to GP, and sometimes they might have certain small changes in their blood test or in their physical parameter, which you may not pick up for years and years and years. I mean, diabetes is one example. High blood pressure is another example. High blood pressure is called as a silent killer, because person can have high blood pressure for years and years and years before any signs come through. But if we make it a habit that every year we'll get ourselves checked, and if there's any small abnormality, we'll keep a close eye and the doctor can treat it at the right time, that can be a preventative thing. Ask yourself, when was the last time you went and got yourself checked thoroughly? I'm not advocating a doctor shopping or a health anxiety related behavior. There people might be going to the opposite end, where they're getting themselves checked, and every little symptom they panic and they go to GP. Not a good idea, certainly, but also avoiding health professionals and doctors and not going and not getting yourself checked for many years. It doesn't do you any good. So that's one thing you can do if you haven't done it, so that at least you know how your parameters are, and you can intervene early enough so that 10 years down the line, 15 years down the line, it doesn't come to you as a surprise.
Absolutely. And this leads us quite nicely on to the question that we had earlier in terms of, is statin use linked to dementia?
Statin, there have been articles and research on that. It's not a well-established thing. I think, it's again balancing the effect of statin on controlling your cholesterol level, because that itself is a risk factor for causing dementia, versus any side effects that you might experience because of statin. So the jury is out at this point in time. It's not something we would advocate people to stop just because of fear of dementia. Because clearly there are consequences of not taking statin. Is if the cholesterol go up and that leads to other complication, you have to balance the thing. And although the research does, there are some articles suggesting that it's not something which has been established well so far.
Okay, and then going on to sort of like the next one is, how likely is dementia to be inherited or passed down generationally?
Indeed, and it's one of the commonest questions I get asked from families, and am I next?
Yeah.
The research is that the role of genetics is there, but it's a relatively small role. And again, as I said, dementia is not one condition. Dementia is a range of conditions. Yeah. So to give a specific advice to somebody, you need to know what type of dementia they have. But if you kind of club them all together, if you read the generic books, what they say is maybe about 10, 12%, 15% role of genetic factors in the dementia happening. The biggest risk factor is, of course, age. We live longer, we have greater chances of developing dementia.
Yeah.
Even for age, just because it is common doesn't make it normal. Even if you look at people over the age of 95 or 100, yes, the probability of having dementia is a lot higher, about 35-40%. But that also means that 60 to 65% people over the age of 95 don't have dementia.
Okay. So here's the thing, because I'm really glad you actually said about age, because one of the things that we've actually, you know, we were discussing sort of like prior to the show was the actual cultural stigma attached to anything to do with mental health. And a lot of communities will just, you know, sort of like push the dementia, Alzheimer's, you know, potential diagnosis out the window and just say, oh no, it's just age. So how do we then, as say the BAME community or the Southeast Asian community, encourage our parents, our grandparents, our elderly uncles, aunts to go through and actually get themselves seen to, if they are sort of like suffering from any of these symptoms? How do we overcome that stigma?
I wish I had a simple answer to that. It is a big challenge which governments and societies have been battling for a long, long time. And you know, it's one of those things. It's not just about knowledge and information. It is about expectation, and it's about the meaning of that label, dementia. You know, people, the word dementia is not just a word. It has an emotional connotation.
Yeah.
And that connotation comes from either your past experience, or hearsay within your community, or what you may or may not have read in the newspapers and books, and there is an element of sensationalism there. Fact that a lot of people with dementia can lead a perfectly normal, fairly decent, pretty ordinary, you know, get on with the day-to-day job and find life, doesn't get highlighted in any newspaper. But if there's one incidence of a fire happening in a house because they left the gas cooker on, or one incident of something odd happening somewhere else, it comes on the front page and everybody, oh my God, they associate having the label dementia to behaving or doing things which are very risky, very dangerous. And clearly, that's why there's a natural tendency to want to avoid getting to that point or getting that label, because that label is associated in their mind with something really dreadful in terms of the behaviors.
Yeah.
And so arguably, and this applies to all the stigmas, all the prejudice, is education and awareness. And it's easy to say, it's very, very difficult to do that. And you know as much as I do, because the NHS, our trust, we have been running campaigns after campaigns. Have we made much headway? Not as much as I would have liked to. Leicester, I'm speaking from Leicester here, and we have one of the third highest BAME of the Asian minority communities, Black and Asian minority community here. If you look at the number of people who get referred to our services with suspected dementia who are from that community, the number is disproportionately small.
Yeah.
And often come a lot late in the stages of the dementia, because the family have been just silently absorbing, suffering, managing somehow between themselves till things reach a point where it can't be contained anymore.
But this is where sort of, you know, saying the actual sort of like negative aspect of it, it's old age. It happens to all of us in old age. Sorry, Mina, I did miss out Mina's question, which was, is depression a differential diagnosis of dementia or a part of it?
It is, well, it's not just a differential diagnosis, it's not just a part of it, but it can be a risk factor for dementia as well. So, you know, when we talk a major depressive disorder, the major depressive disorder is a group of some functional mental illnesses. And if you look at the symptoms, particularly if it's happening in the elderly people, there can be a significant overlap between the symptoms of major depression and early symptoms of dementia. There are a few ways to clinically differentiate, but it's, again, like most things, it's not 100% accurate the way to differentiate, and one has to keep the index of suspicion fairly high. And if there is a little doubt, there's no harm in treating major depression as well we know that from the research studies, major depressive disorder is also known to be one of the risk factors for dementia. And it could be either a direct effect or it could be an indirect effect that, people with major depression, if they had for a long period of time, may not be following some of the healthy lifestyle or being as active mentally and socially. And so it could be a direct effect or an indirect effect. The third thing also is sometimes mood disorder, mood changes can be a consequence of the damage to the brain, i.e. they could be part and parcel of a dementia syndrome where the mood is affected disproportionately. And although there are clinical ways to differentiate between these three, and that's why, when you go for an expert assessment, hopefully the expert can listen to you, talk to patient, do an assessment, be able to have a reasonable idea whether it is one or the other or one of these things. So yeah, a major depressive disorder is a differential diagnosis and is also a risk factor for developing of dementia.
Okay, brilliant. Thank you. Now, we've had a few other people joining us. So Manish Pandya has joined us. Pramila Stankia is watching with us. So we've got and Rakesh Kumar Varma is watching with us. So we've got a few other questions. So Yasir has said that he's just realised it's not his dad, but his mother is also showing signs of personality change over a period of time. Extremely informative. Thanks for having the conversation. Rena has said, I hope you guys do a part 2 to this, as we appreciate it's a vast topic. And Rena, both Mangesh and I were discussing this, and we do feel that it does need to be a few more shows covering Alzheimer's and dementia.
We can have some focused discussion on certain aspects, because as you quite rightly said, it is a vast area, can't be covered in one go in a kind of sensible way.
Absolutely. And then Manish has said, thank you, really helpful. Quick question, to offset statin usage, do you recommend using COQ10? I have heard this from various sources, but not a medical doctor.
Okay. The simple answer is no, I don't. And that is not to suggest that there are not articles and research. The difficulty with research in dementia field is that there are, at any given time, there are several tens, if not more, different promising clues that we get from different research. For that to be included in our clinical practice, there is a long transition period, which requires, number one, the replication of that information, of that study finding into other, because sometimes you can have research finding which don't stand the test of time and repeat checks in different settings, in the different contexts with different research team. So while those research are important telltale signs and you have to kind of look at them and investigate them more, they are not offered, the evidence is not of a degree to actually include it in your clinical practice. And again, if you go on the Google and search for diagnosis of Alzheimer's dementia, I can bet you'll find several genetic tests or other kind of cognitive tests, or either electronic or otherwise, which can diagnose Alzheimer's dementia. The fact is, none of that research is robust enough to be used in a clinically meaningful way. For research, as a question, as an idea to explore further, of course, those are interesting threads we need to follow. But sadly, the experience says that a lot of these threads don't take us anywhere. And if we spend our clinical or financial or other time on that, often we are on a wild goose chase. We don't get anywhere with that.
Thank you for answering that. And then we've got this is a very interesting one. This was actually one of the ones that that I was going to ask you. Is there an ethnic predisposition to dementia?
Broadly speaking, no. The prevalence of dementia doesn't change a great deal between most of the ethnicities. There are a very small minority of ethnicity where there is certain genetic predisposition which makes certain young onset Alzheimer's dementia or certain forms of dementia more common, but those are extremely rare. For bulk of the, the blacks, the Asian, the Caucasians and others, the overall prevalence of dementia is by and large similar to each other. What has been described as slightly different is what type of dementia, and that also varies between the women and men. There's a gender difference also, whether Alzheimer's is more common or vascular is more common. Some of it is based on your risk of diabetes and stroke, because they are the risk factors. And if you're getting stroke, then clearly you're more likely to have vascular dementia. So while there are certain differences between different ethnicities in terms of what type of dementia they get, overall prevalence of dementia in different ethnicity groups is much the same.
Okay, and Manish has asked, do you also recommend red light therapy?
Tell me about that. It's one of those things which I not read a lot about. It's not something which we use in practice. So I wouldn't necessarily know what exactly it involves.
Yeah. I mean, I think there's been a lot of sort of like, I think they're using a lot of light therapy in some of the other therapy areas, aren't they? Because I know they use a lot of it within dermatology. So to be honest, I'm not fully up to sort of like scratch on red light therapy in dementia myself.
Well, I mean, in terms of therapy, we'll perhaps come to therapies in different ways. When you talk of therapy, you're talking of 3 or 4 different things here. And sometimes we need to be clear, what do we mean by therapy? So let's be very clear. Until now, so far, we have no therapy, no treatment which can undo the damage or cure the dementia.
And this was the question that we were going to come to. And, thank you for leading on to this, was, in terms of therapy and sort of like the treatment, what are the treatment options for Alzheimer's and dementia? And then thank you for sort of like, saying about the...
Yes. And when we talk of treatment for dementia, we are talking of mainly, and normally I say there are 3 things. We want to do 3 things. Firstly, we want to reduce or prevent the illness getting worse. If we can do something to slow down the memory symptom, the dementia symptom getting worse, not necessarily cure it, not necessarily stop it completely on its track, but instead of getting worse over, 3 years, if we can get it over 4 years, then we really slowed down the progression and given additional abilities for that person for a bit longer. So that's one part of the treatment where you're talking about slowing down or reducing the speed of decline of illness. The second treatment we talk about is what is known as symptom relief. So, it's not the illness, but the symptoms of the illness. Can we do something if the person is very anxious and frightened because of their forgetfulness? Can we do something to alleviate that anxiety? If the person is not able to achieve certain, activity, can we facilitate that from happening? And the third is to minimize the negative consequences of their illness or their symptom. So again, one of the sad things which we encounter is a lot of elderly people who, more so if they are living on their own, might be vulnerable to exploitation by other people or door-to-door salespeople, pressure, telephone sale. And we hear horror stories every so often where somebody was fleeced out of their life's earning by some con man or con person under different guises. So coming to the first thing about what can be done about slowing down the illness symptom getting worse. But the first thing I'm going to have to keep repeating myself, which is the healthy lifestyle factors are still valid once you have got dementia. It has a preventative role. Besides that, for Alzheimer's dementia, certainly, there are some specific licensed medications which have been available for last 20 plus 22, 23 years now. And for people who are suitable and eligible, those medicines are available from NHS or from your own doctors. Of course, they are not a panacea and they are not a kind of magic pill. They have their own health side effects, and you have to kind of keep a watch on some of the heart rhythms and kidney function, depending on which medicine. But they are available and they benefit a number of people. It's worth being aware of that. So those are the kind of main thing in terms of what can be done to slow down the process of the illness getting worse. Coming to the second thing, as I said, in terms of the symptomatic treatment, depending on what the symptom, what the issue is, there are management strategies of different kind. Again, you can have different symptoms, and I can't give a long lecture on that. That's a very focused focused topic to discuss on its own. But one thing I would mention here is, and in this modern age, and particularly nowadays, we all are aware, sometimes the key is on making sure that person is independent, they are safe, and they have a good quality of life. And sometimes these three can be at loggerhead. If you're too independent, then it's too risky. But if you're too safe, then your quality of life might be affected because you are just wrapped up in a cotton wool and kept somewhere safe. You're not enjoying, because part of the fun is taking risk. It's a very dynamic balance between these three things: maintaining your quality of life, maintaining your independence, and reducing risk or maximizing safety. And that's why it has to be tailored to a given person rather than having a universal formula applied to everybody or anybody. The assisted technology or the computerized gadgety stuff that have come in the market over the last few years have helped people maintain their independence and safety enormously. And it's quite heartening to see and again, people do very simple things. It doesn't have to be rocket science. A simple panic button, so that if the person falls in the garden, they can do that and get help rather than be stuck there for several hours before somebody notices it. Ways of remote communication. We are doing it as we speak now. That sitting here, I can see that you are keeping okay, and you can see I'm keeping okay. Why can't it be done with the patient and their families? There are ways we can, and the gadgets can be used to make sure the person can cook safely and the fire risk is minimized. There are simple things which can shut off the gas supply if it is lit and there's no flame, or if there's a detection of any smoke or any particular temperature. You can have safety measures in place. Again, not that I'm subscribing to one or the other, but these Alexa and other kind of devices, they can answer the question hundreds of times without getting irritated, as opposed to the family members having to repeat the same answer 3, 4, 5, 6 times. And so on and so forth. They are disabled-friendly gadget, disabled-friendly, including dementia-friendly, source available. GPS tracking watches. I vividly recall a shopkeeper friend whose father enjoyed walking long hours and hours of walk, except because of dementia, that father was not able to know where he is and would often get lost. A GPS watch enabled this person to allow his father to go for walks and to track them where he is at any given time. If he's not home at a certain time, he could go and pick the father up from where the father is. It allowed the father to maintain his quality of life, because that's what father enjoyed. It reduced the risk and also reduced the stress on the carer, on the son who was a shopkeeper and who had to be at his shop. He couldn't just go every time there was any concern, So I would say it's an evolving field. It's a very promising field. I'm quite hopeful of that this will kind of reach a point where it can be used to really help people with dementia live safely and independently and enjoy themselves a lot more than what they do now.
And that's just it, isn't it? It's the quality of life. So we've had a few more people joining us. We've had Veena Trivedi joining us, Nitani Mangalani, Jyoti Davar, and sorry, I can't pronounce it. Mridranal, sorry, forgive my pronunciation. Bundambagar, sorry, excuse my pronunciation. So we've had a few more comments. So we've got Nasir Alam. Now he's saying that they've created an AI predictive healthcare system for all segments of society. And he's basically asking, how can you help us in recognizing dementia patterns and generating predictive insights for the elderly people? What I would suggest, Nasir, is maybe take that conversation offline with Mangesh directly, because Mangesh is on LinkedIn as well as Facebook. So maybe take that conversation offline, because I think that will.
Let me make a pertinent comment. I think, Nasir, I'm glad you're working on that field, and I hope you come up with something which is useful to everybody. One of the biggest limitations we have been aware of in NHS or in clinical health sciences is the gap between the research and the clinical practice. The two, the long gap. Somehow the translation of the knowledge we gain in the clinic and in the research field doesn't get implemented into the clinical field. And there have been discussions on why is that gap, why is there delay. So something has come up in a kind of research field, it takes easily 10 or 15 years before it comes into the clinical practice. And there are whole sorts of reasons for that. And one of the reasons, and one of the area which is again in coming up is what is known as translational research, whereby the research is done more in the real life situation rather than in a sterile lab ideal situation. Often when you do initial research, it's done a very selected, very, relatively speaking, a narrow group of conditions, or there are lots of exclusion kept really to make it more meaningful. But then when you bring it into real life is full of diversity, full of idiosyncrasies, full of, whole range of things. And you find that thing doesn't quite work in real life. And there are safety issues, there are health issues, all sorts of issues why that delay. And that's a very frustrating thing. And there's a whole range of evolving field on translational research, where the focus is really to study how we can bring the knowledge gained in research quickly into clinical field. So I'm glad you're there, and I'm happy to talk to you offline in whatever we can help you.
No, that's brilliant. Thank you so much, Mangesh. Now, we are sort of like, we have gone way over time, but that's fine. I mean, I think this is such an interesting discussion. And I think, really, if we look at the comments that are coming in, people are watching, I think it's such a pertinent subject area that, and people really do need to understand this. So Sonali has said, very informative session. Thank you. Is it true that playing some tricky brain-teasing games, puzzles daily can prevent dementia?
Well, yes and no. I think I said to you before that keeping mentally active is one way to either prevent dementia coming or delay or slow down how quickly it gets worse. I said that across the field of old age psychiatry and dementia research, one of the common finding is that you get better at what you do, nothing else. And so, and one of the things I said, that how often do we need Sudoku skills in our day-to-day life? I practice, I've been doing Sudoku for fun, but I would say keep your mental activities which are relevant from your day-to-day part of the life. What you need in day-to-day life is be able to remember a list of shopping items. What you need in the day-to-day life is remembering names of your family and friends and acquaintances. What you need. So mental exercises which aim at these things are a lot more likely to prevent the symptoms from happening or reduce the symptoms from getting worse. And some of the examples of that I can give you a fascinating example. I guess anybody working in the field of old age would have possibly seen one or two or more. But we had nearby, there's a residential home where there's a gentleman who has got quite severe dementia. But bring him in front of a piano and he can play the whole Mozart, without thinking twice, talking to you. Such a overdeveloped skill that he can still maintain that skill despite so much happening. We had a gentleman with significant memory problems, significant dementia, to the point where their lots of brain abilities were impaired. But one thing they were good at was their driving. And the reason was they spent their life working as an advanced driving instructor. So it was such an overlearned skill that they could do it without having to think and do anything additional. The brain was just overdeveloped in that field. So with training, you get better at what you do. And in terms of dementia symptoms, any mental exercise is better than nothing. But within the range of mental exercises, what are more practically applicable or useful or things which you need in your day-to-day life anyway. And so I would say, yes, the brain-teasing puzzles are good. They are problem-solving. They're excellent. But choose them, if you can, those which have practical application in your day-to-day life.
And it's like you were saying, it's very interesting because I suppose it's like, your body has muscle memory. So if you were very slim as a child or a teenager, then, they say, and it's slightly different, but it's easier then to lose weight because your muscle memory is there of, the slimmer, more toned muscles.
I would rather not make any comment on the weight and the muscles at the moment.
But it's the same. I'm saying muscle memory and I suppose brain memory. Okay, so we've covered so many things. We've covered sort of like the stigma. In fact, I think with all the questions that everybody has been asking, we've covered so much. And one of the last things, which I think, again, thank you, Nasser, for bringing up the technology. We did also cover sort of like assisted technology, which again is something that can help people with their quality of life, because that's what it's about at the end of the day, isn't it? It's about having that quality of life.
Can I also, now that you mentioned quality of life, let me also mention something because we are running short of time. You mentioned right at the beginning about the immediate family member and the impact on them. And I must say it's a topic which is not spoken a lot. And sadly, it needs due attention. It needs, and I would spend a few minutes if you don't mind on that, because as a family member, it is hell of a job sometimes to convince the person that they need help, because clearly the person sees it from a different point of view than them. So the chances of arguments and disagreement can get multiplied. Because it generates that irritability and angerness, there's also an element of guilt because you are getting angry at somebody you love the most. And so it's very hard to have these feelings of anger that why can't he or she listen to what I'm saying, and why keep digging, but also feel very bad and blame yourself. No, maybe I need to do something. I'm not doing something right. Somehow if only I could do things the right way, it would be a problem. And that guilt and that anger together can be very, very damaging to the person, the carer of the family.
Yeah.
And often the pride, the shame, that stops them from seeking out help. People don't shout and say, you know what, I not slept for last 2 nights because X happened and my so-and-so was awake and was asking me this and that and other. They will kind of, tag along till they reach a breaking point.
Yeah.
And again, that pride and the shame that, oh, I'm not good enough carer, I'm not good enough spouse, I'm not good enough son, daughter, whatever, daughter-in-law, and you name it, can be very hurtful for that person. It's all bottled up anger, bottled up guilt. And sometimes having somebody to talk to, find that you're not alone, can be such a relief, such a big relief. And before the lockdown started, Alzheimer's, dementia, age UK, and some of the other with the help of local social services and health services, we used to run carers group regularly. They were such a highly welcome groups and activities. So many relatives, so many family members were just so relieved to hear that they are not alone. And beside that peer support you get, you also sometimes find little tricks that worked, and it's a matter of trial and error what worked best for you. So simple thing, somebody said, oh, my so-and-so keeps asking me same question, and it just kind of winds me up, and I said, okay. One other trick was, okay, let's have a whiteboard or a blackboard, because the question they ask are not many. They are the same 4, 5, 6, 7 questions which they ask tens of times.
Yeah.
So rather than replying to them, if you write the answers on the board, and every time they are just point to the board, they will get to know, and their information will be there, so that the person themselves are satisfied that they have the answer. And the carers don't have to go through the frustration of having to repeat themselves a number of times. And that kind of simple trick that you learn from family members and other relatives who have been through the situation or who are going through the situation can be phenomenally educational. I gained so much from family members. I can't begin to describe that.
Yeah. And it's, hopefully we can start these groups up again once we're out of lockdown, or maybe there might be some on, online. But, I know like some of the things that that can also get very, very frustrating is these sort of like non-stop chatter. And some people, in some cases, they call it sundowners, but with some patients, they will have that, they'll have days where they literally do not stop talking. And it's like all day. And you get to that point where you're just like, oh God, I need some peace and quiet, stop talking. So, it's about sort of finding sort of coping mechanisms with that.
Absolutely. Getting support early, because these, again, going back and repeating, these are chronic conditions. This is not for 1 month or 3 months where you can say, okay, if I can pull through somehow for next 2-3 months, everything will be okay. No, it won't be okay. And so it's a long haul. You have to kind of maintain your quality of life as much as you need to. And having periodic breaks, having respite. They say, you know what, I need to go away for a week of holiday, but I can't leave my loved one on their own. I need to get help. And you don't need to delay your going on holiday, or not nowadays, but what I mean, a break, before you reach that kind of crisis point. If you take a break early enough, hopefully you won't reach the crisis point. And that old adage of a stitch in time saves 9 applies here. You have to do a little and often to maintain your own well-being, because the best way you can help somebody else is by being healthy and happy in yourself. And often it's another subtle point. People with dementia often may not remember what you said, but they can often remember how you felt. So they can remember that my daughter was angry and upset. They may not know why. They've forgotten that. And that can upset them themselves. So it has almost a kind of reverberating effect, if I can put it that way. And so looking after yourself is as important as looking after your loved one. You can't look after them well if you're not well.
No, absolutely. And that sort of like brings me to the quote that Maya Angelou said. It's like, and this does relate very much to what you said, is that people will forget what you said, but they'll never forget how you made them feel. And I think that's something that we need to remember when we're dealing with patients that have got mental illness. So I'm just going to go through a few more comments, and then I'm going to ask you for some final words before we say goodbye to everybody. So we've had so Najee is saying thank you, he'll reach out to you. We've had Mangesh saying very useful and informative. Thank you both for this interactive discussion. Usha saying very helpful, informative session. And then it's so much reliance on technology by children. Well, actually, we've not covered this. This is a question saying, a lot of children are actually relying on technology. Is that going to increase their risk for dementia in the future?
I wish I knew the answer. I'm sorry, but the research is not yet done, because only time will tell us how things unfold with this. There is no a priori reason to believe that or think of that, because if you kind of want to logically kind of conclude that there is no face reason to think that might be happening, but science has surprised us a number of times in the past, and we are willing or prepared to be surprised again.
Yeah, and also with something like that, it's going to be a longitudinal study, isn't it, over the next X number of decades to be able to.
When generation hit that risk age, that's when we will perhaps start finding the answer.
Yeah.
Until then, it's a speculation or a calculated guess, no more than that.
Yeah, no, absolutely. So, you know what, Mangesh, thank you so much. We've had lots of people saying thank you. Ruxa Shah has said, Dr. Phil Hammond said once that give someone a pair of knitting needles and some wool, it helps people with dementia. So there's lots of different coping mechanisms, aren't there? So
indeed. And maintaining hobbies in terms of quality of life for the person with dementia, I think if we can somehow support them doing what they love doing, it can be phenomenally therapeutic. It can be therapeutic for you and me. Why single out people with dementia? If something you have done all your life, but you didn't get to do for the last 10 years, and then you suddenly are able to do it again, it makes you happy. It happens. It happens to all of us. So following your hobbies and interests is a quality marker for all of us. And it applies to dementia people as well.
Yeah, no, absolutely. So have you got any final words before we sort of and like I've said to the audience, you know, we will definitely be doing another session. We'll just sort of after this, Mangesh and I will get our diaries together to put another date in. But have you got any final words for the audience?
What I started with was that there is a dearth of knowledge in the dementia field, you know, and not that I want to kind of comparing any illnesses is a bad thing. One should never do it. Every illness is unique in its own, and every person is unique. But when you're talking of research, sometimes you have to land up comparing numbers and those kind of things. And what I say to people is, compared to the studies and research done in cancer in the last 20-25 years, where the studies and research have included people in tens of thousands, really, dementia studies struggle to get numbers. And our knowledge is limited. We are still at the early stages of gaining knowledge on dementia. If possible, please do join. And there's at least for the UK audience, I can say that there's a joint dementia research website where you can join through Alzheimer's Society phone number. And anybody who has dementia, anybody who looks after somebody with dementia, anybody who think they might be at risk of dementia, they're worried, they want to take part, do join research, because that's the only way we can gain and learn more. And that knowledge will help us to improve the treatment and the management of future generations. So it's one plea for me. And the second is look after yourself. You know, common sense, sometimes when the science is not adequate, common sense and the art is what matters the most. So you look at the person, don't just follow something blindly because you see it on some kind of website. There are so many different websites, and no disrespect to them, but for things to be used in your data, don't spend your money onto things which are experimental, things which are, you know, you don't know the ins and outs of it. So go for trusted and reliable, you know, sites, and ask somebody locally. You know, there are GPs, your dementia advisors, there are Alzheimer's Society, Age UK, and other, you know, they have people who are vetted, people who are trusted, who one would like to say are non-biased and are not commercially driven. Do talk to them before you invest any huge sums of money or time and effort into something which somebody somewhere said worked for them. Yeah, we need more knowledge. Thank you.
No, absolutely. And I'm really sorry, there is one final question because I think this is quite pertinent. So Jay's just joined us from the USA, and he's actually asking, his mother has dementia and she's at a stage where she holds water in her mouth. How do you help her swallow?
Okay. Holding water in the mouth for a long time, again, I don't want to make kind of very personalized statement because there are a number of possible reasons why that happens. One of them could be there could be a swallowing mechanical problem with the swallowing in the throat itself. And that can happen sometime when the dementia reaches a certain point where the coordination of the muscles needed to swallow can be compromised. And in those situations, I would say a speech and language therapist or somebody who is able to make an assessment of their local throat and mouth region to find out why that person is not able to swallow promptly would be the safest thing to do rather than make a judgment as to why they are not swallowing. It needs a personalized assessment. But yes, it is known that in certain, when the dementia affects certain parts of the brain where the coordination of the muscles, Parkinson's disease is one example where the coordination of the muscles can be affected. In that, I'm just giving one name, but it can happen in Alzheimer's, it can happen in vascular dementia, it can happen in other conditions. So before you kind of start treating or dealing with it, better is to get a speech and language therapist to do an assessment and then have a very tailored intervention. There might be other ways of managing it, or medicines possibly, depending on what is the cause of that problem.
Brilliant. And thank you all Thank you all. We've got so many comments still coming in, and what we will do is we are going to have to go now because we are sort of like way over time. But we will definitely be doing a second session on this because I think there are so many questions that are still coming through. There are so many areas that it is such a vast area. But Mangesh, thank you so much for taking time out.
Thank you for inviting me, and thank you to all the listeners, and it's been a pleasure. I wish I could answer your questions more personalized, but we'll have to do with this for the time being. But I'm more than happy to have further comment questions and be able to hopefully advise and learn from you guys. And you tell me more than what I ever tell anybody. So I'm always willing to listen to your experience and what works for you.
Yeah, and I think maybe next time we might maybe be able to get a few, maybe some patients on or some carers of patients to actually have a wider discussion. But let's see. But yeah, Mangesh, I'm going to sort of like let you go for a few minutes, and I'll come and talk to you in a bit so we can sort out the next session. Thank you so much. Honestly, it's been such a great talk, and I think we can see from.
Best of luck to you, and best of wishes for the show.
Thank you very much. Thank you, Mangesh. Take care. Namaste. So that was Dr. Mangesh Marudkar, amazing psychiatrist. I mean, like I said, I was very, very blessed and privileged to have worked with him in a different life. He is amazing, so knowledgeable, very patient, very kind, and I learned so much from him. So thank you all so much for the great interaction. I hope we were able to answer as many of your questions. And if there are any people watching that I didn't call out to, I apologise. But thank you so much for watching the show. Now, please do share, because we do know that this is such a pertinent subject. Please do share this show with as many people, as wide and far as you can, just so we can get the information out there, so people know that they're not on their own, especially now during COVID, where we are all so isolated and we may be living with family members, or we may be living with it ourselves and not know where to go. So let's share this, let's get the word out there. Right, so I'm going to be logging off shortly, but before I go, next week's show is going to be at the later time of 5 p.m. As you all know, I'm hosting another TV show, another chat show for Healing Little Hearts called HLH TV. So that will be on next Sunday at 12 p.m. And my show, The Double 15 Minutes, will be on at 5 p.m. Next week, I've got Claire Walker and Luke Martin. They're both consultants in domestic abuse. So next week, we're going to be covering domestic abuse again, because we're doing this as a series of shows, because there are a number of issues around domestic abuse that we would like to cover. So that's going to be next Sunday, 5 p.m. And the Cell Provocateur podcast has gone live on Spotify. And on that, I was talking to the stunning Cypria, who has released her new album called Kirtan for the Soul. So yeah, do check that out on Spotify as well. So in the meantime, thank you all so much for joining, all the comments. The interaction has been absolutely amazing. And thank you, Mangesh, again. You've been absolutely fantastic. So on that note, I'm going to say thank you for joining us across Facebook, LinkedIn and YouTube. If you do have any questions that we've not been able to answer, please put them in the comments and we will do our best to get them answered for you. So until then, I will see you next week. Stay safe, everyone, and stay as happy and healthy as you can. Take care.